Hello everyone, I am Kaveri, a third year physiotherapy student, and my topic for medicine is mitral valve stenosis and oxygen therapy. So, topic 1 I will explain is causes of mitral valve stenosis in CVS, valvular heart disease, and mitral valve disorders. And topic 2 I will explain is oxygen therapy for respiratory failure from respiratory system. So, what is mitral valve stenosis? First of all, so it is narrowing of the mitral valve orifice that obstructs blood flow from the left atrium to the left ventricular during diastole. So, how it will happen? So, left atrial pressure will rise first, then pulmonary congestion will happen, and patient will feel breathlessness and chest pain. What are the causes of it? So mainly are rheumatic fever, congenital defects, and Lutem-Baker syndrome. So 90% of the cases of rheumatic fever are there caused by streptococcal infection triggers autoimmune infection leading to valve defect, fusion and progressive narrowing of the mitral orifice. Their congenital defects include parachute mitral valve and commissural fusion present from birth, where Lutem-Baker syndrome is a rare combination of mitral stenosis with atrial septal defect causing mixed hemodynamic compromise. So what are the main causes of it? Calcified mitral annulus, commonly in elderly. Functional obstruction could be ball valve, then thrombus, then autoimmune disorders will be SLE, RE, RA. Others are Hurtler syndrome, endomyocardial fibrosis, then juvenile mitral stenosis. And for the note, functional obstruction mimics true stenosis by impeding mitral inflow without structural valve fusion. Autoimmune and metabolic causes are rarer but clinically significant. Then oxygen therapy for respiratory failure. Exploring the principles, methods, and clinical application of oxygen therapy in managing hypoxemia and supporting patients with acute and chronic respiratory failure. So, oxygen therapy we mostly use for the patient who needs oxygen therapy. So, what are the now types of respiratory failure? So, type 1 will be decreased O2, hypoxemia, and normal CO2, normocapnia. And for the type T, decreased O2, hypoxemia will be there, but increased CO2 will be there, means hypercapnia will be there also. So what will be the causes for type A? Pneumonia, acute respiratory distress syndrome, pulmonary edema, pulmonary embolism, asthma, the acute one only. Then for the type 2, causes will be COPD, neuromuscular disease, severe asthma, chest wall deformity, central respiratory depression, etc. Then what is the therapy? The oxygen therapy, low concentration O2, high flow systems, CPAP therapy, and mechanical ventilation we could do. And what will be the aim of it? To control hypoxemia without causing CO2 retention. That will be the aim of the oxygen. So we could do it by the nasal cannula or the tight fitting mask recruits, which will do the improve the gas exchange. The mask will do it, and via the cannula we can give the oxygen if there is a low oxygen, but these both are not that much relevant in today's cases. And if the PO2 is not maintained, what will happen? The intubation will happen plus mechanical ventilation will happen also, and it will indicate the chronic severe hypoxemia at the end, and the patient will need oxygen therapy. So what will be the physiotherapy relevance for it? Why we need to know this stuff? So first of all, while treating the patient having these two, we will have to consider verify O2 delivery method and target saturation before the treatment starts. And after the delivery of treatment also, we will have to monitor O2 continuously during chest physiotherapy and mobilization or any therapy also. Then, and the patient having these, we need to take care of the position of also, like positioning the patient upright or prone. It will improve the oxygen significantly while the therapy and after the therapy also. Stop or pause therapy if O2 drops below the safe range. So both conditions require careful physiotherapy monitoring as well. Thank you, and here is